Hey, what's up, everybody? It's Jason Goodwin. I'm here to teach you about patient education. This is for first semester nursing students, chapter 16, Wilkinson's Fundamentals of Nursing, Davis Advantage, and that is the fifth edition. So let's get started, shall we? Okay, so a couple organizations that have to do with teaching clients and some understanding parts of independent nursing practice. So the basic purpose of us teaching and learning is to provide information that can empower our clients and families to number one, perform self-care, and number two, make informed decisions about their healthcare options. Okay, that's a lot of what we do in educating people. And like other interventions, you can use teaching to promote wellness, prevent or limit illness, restore health, adapt to changes in body function, or facilitate coping with stress or illness or loss. Those are all things that we do on a regular basis as nurses. And the ANA, the American Nurses Association, has a standard that they put out, and the registered nurse seeks knowledge and competence that reflects current nursing practice and promotes futuristic thinking. Registered nurses' teaching activities include providing health teaching that addresses such topics as healthy lifestyles, reducing risky behaviors, developmental needs, activities of daily living, and preventative self-care. Another thing they do is using health promotion and health teaching to appropriate to situations and patient values, health practices, and developmental levels. We use those to address learning needs and readiness and someone's ability to learn, even language preference, spirituality, culture, socioeconomic status. We've gone through all of those. So those are all things that we do, right? You can acknowledge that and that speaks true. We seek opportunities for feedback and evaluation from our patients after we've done those things and when we're reviewing and reflecting on what our interventions, what effect they had, right? So we also use that information and technologies to communicate health promotion and disease prevention information to a larger scale, like the healthcare consumer. We do that to a variety of settings, right? Whether it's school nursing or public health or, an individual diabetes educator for a unit, right? So on different levels. And then we also help them on understanding the intended effects of potential adverse effects of certain therapies. And that's part of informed consent as well, right? So that's part of what we do. The other part, a company you might have heard of, the Joint Commission. The nurses have an obligation, according to them, to consider the literacy, desire, and motivation to learn. This is part of our responsibility as educators. Developmental and physical limitations, barriers in communication, culture, and religious beliefs of every patient. Now, remember, one of the things that is specific to nursing scope of practice is our ability to educate patients. So we take this very seriously, and we have a high bar for our professional standards, particularly when discharging a patient and things like that. So that's important stuff, right? So we have to understand that that's part of our role. And then finally, the American Hospital Association, also called the AHA, in 2003 released the Patient Care Partnership. And it used to be the Patient Bill of Rights. It's still called that in a lot of cases, but it's technically called that now. It describes the right of consumers to accurate and easily understood information about health plans, their professionals, and their facilities. If they speak another language or have some sort of a disability, they have the right to receive that in a way that they can make an informed decision. Okay. So you will see that a lot of times when you enter a hospital, there will be a notice of patient rights on the wall just inside the doors. That's required by Joint Commission. So that's one of those things that you might see if you're looking for it. Okay, why is patient education important? Well, for all these reasons, right? It empowers patients, it improves patient compliance, but it's not just about dispensing medication, right? Or administering treatment. We're about educating patients. We prevent and manage healthcare conditions. We promote their health of different people. With health information, we take patients and we help them take control of their own care, right? So we influence them. We participate in these decisions with them. We advocate for them. We take an active role in some of these decisions about their health, and that's appropriate with advocacy, of course. So we help them make informed decisions. We cannot obtain informed consent from a patient. That's a physician responsibility. But we often are the ones helping interpret some of these difficult decisions and understanding the pieces of the puzzle, and we can help them put them together. We can help patients get answers to questions, find resources, recognize problems, or develop self-care behaviors. Usually hospital stays are brief, and so we have a responsibility to teach a family member how to provide care and teach patients to care for themselves as they're able in a very short time. So part of our role is to do that quickly and oftentimes under duress, right? So we do that because that's part of our identity, and we do that well for the most part. Healthcare is expensive. Patient education can help to decrease the overall cost of healthcare. An example of how to do that would be teaching a patient with a chronic disease how to manage that. And I think I said this in a prior lecture, but George Halverson said in his book, Reform Healthcare Now, book from the early 2000s, he was the leader of Kaiser Permanente. He said something like that the top 5 chronic diseases in the world could be managed in American care, could be managed. 80% of the cost could be removed from healthcare if those conditions were managed well, right? So this is what that's talking about, is if we're able to manage diabetes well enough to where less people have it, if we can manage hypertension, if we can manage congestive heart failure, and things like that, right? So those are the things that when we shorten hospital stays, we reduce readmissions, we prevent people from being admitted to the hospital. That all costs less for our healthcare system. Okay, so we're going to go into the 3 domains of learning. And so the first one of these is called cognitive learning, okay? And this is about storage and recall of the information in the brain, all right? Facts ranging from simple to complex processes. There's 6 levels of behavior, as you can see here, right? And so we have memorization, recall, comprehension, and analysis and synthesis, application, and evaluation of ideas, okay? Strategies and tools to support teaching cognitive type content include lectures, reading materials, panel discussions, audiovisual materials, web-based or mobile application, right? These are didactic synthesis of information, okay? This is what we do in lecture. Psychomotor, this is our hands-on, right? Some people say they're kinesthetic learners. So psychomotor learning involves learning a skill that requires both mental and physical acuity, okay? So it requires a client to accept the value of the skill. That's called the affective domain, as well as know about the skill, the cognitive domain. Strategies and tools used to teach psychomotor skills include demonstration and return demonstration, simulation, mannequins, audio-visual materials, streaming material, and journals and self-reflection, printed materials, especially when they have like photographs and illustrations, right? So when we're talking about this education, we're talking about in the manner of us providing it to our client, right? So this isn't about our learning. This is about them learning and how we help them facilitate that. All right. So notice that at the beginning of what I was talking about, I said something about the fact that it's important for the client to accept and value the skill, right? So that means that number one, you have to look like you are confident when providing the information. That's important, right? Because you have to obtain their trust and you have to establish rapport. The second part is they have to understand that there's a reason for it. So explaining why you're doing it and why it's more important, or it's helpful for them to do that is critical, right? And so that's why we do that, and that's why it's really important for you to explain these things to your patients when you can. All right. Okay, effective. We talked about this a second ago. This is changing feelings, beliefs, and attitudes. So these are strategies and tools for promoting effective learning. It includes role modeling, group discussions, role play, storytelling, mentoring, one-on-one teaching and discussion, and then even audio visual materials and interactive applications like VR or anything like that, even digital and printed materials. Okay, so these are all things that can help us. Then there's other theories of learning. So we've talked about the different ways people learn, but these are different theories that explain the characteristics of how people learn. Okay, so the social learning theory explains characteristics of the learner. All right, and that includes self-efficacy. That's a major concept in social learning theory, and it's a major concept in all education. Self-efficacy means that it refers to the client's perceived ability to successfully perform a task. So they have to be able to do it on their own. Okay. Behavioral learning theory is one of the other theories. It's characterized by identification of information to be taught and immediate reward for correct responses. Okay, so it's behavioral, right? So there's a reward system, and it has roots in psychology, as you probably would guess. And the belief is that the environment influences the behavior, and in fact is the essential factor in determining human action, right? So this goes back to Pavlov and B.F. Skinner, right? The conditioned response. So Pavlov was a behavioral learning theorist. And then we have cognitive theory, which sees learning as a complex cognitive activity, mental activity, right? So learning is intellectual or thinking process in which learner structures and processes information. The cognitive theory also recognizes the importance of developmental stage and social and emotional and affective influences on learning. Bloom is one of the major cognitive theorists. You may have heard of Bloom's taxonomy. Those are some of the models that are used in that. And then humanism focuses equally on the learner's affective, emotional, and then cognitive, intellectual, and attitudinal qualities. So it's more of a blended version of this. And it emphasizes the active participation and responsibility of the patient in the learning process. Okay, it's thought of as self-motivated, self-initiated, and self-evaluated, and so it's very much a focus on trying to get the patient ready in many ways to accept the change and initiate it. Okay, so we had the 5 rights, what's like 7 now, right? But the 5 rights of medications, there used to be 5 when I was in school, by the way. But now there's the 5 rights of teaching, right? And so when you're making a teaching plan, you can use this list to determine whether you've done the right thing for the patient, right? So number 1 is it the right time? Is the client ready, free of pain, anxiety, or any other distractions? Have you or the client developed a rapport, as we talked about? Is there sufficient time for the teaching session? So, okay, is the patient's in pain, right? They're not going to be ready to hear it. If the client doesn't trust you, obviously that's not going to be effective. If you're about to teach them about their insulin and then they have to go to it for a CT scan, that's not going to be enough time, right? So those are all the things you have to make sure. The next one is the right context. So is the environment free from distractions? Is it private, right? Is it quiet? Is the environment soothing or stimulating, or is there some other effect that might affect the teaching? Okay. The right goal. So is the client actively involved in planning the learning objectives? And are you and your client both committed to reaching mutual sets of goals for learning and desired behavioral changes? So as nurses, what we develop goals, right? And we're doing this in clinicals all the time. And we work on things like, the patient will walk 3 laps around the unit with an assistive walking device, by the end of the shift, right? Well, if as a nurse, if you're not prepared to help them do that and there's nobody else to do that, you're actually not mutually bought into that goal either, right? And even if they are motivated to do it, then that's not likely to happen. So there has to be a shared agreement and commitment to getting that done. And oftentimes we're, obviously very supportive, and that's not the main issue, but it does have to be both ways. And sometimes that can happen too. Are you and your client both committed to reaching? Okay, we talked about that. Are family or friends included in planning? so that they can help follow through on behavioral changes. So this is important. You've probably seen this already because being in the clinical, you see very quickly that the family has a very big influence on what the patient's going to be doing. They can contribute to the stress, or they can help facilitate success, right? So, and then also, are the learning objectives realistic? Just like when we do SMART goals, right? We talk about, is it what's the SMART? Is it sustainable? Is it measurable? Right? All of that kind of stuff. Is this objective realistic? And can they actually do it in their current lifestyle? Right? And then, like for instance, you're not going to tell someone that's morbidly obese that they should start running a mile tomorrow. They're going to have to work into something a little bit more realistic, right? And so, the next thing is the right content? Is the content appropriate for the client's needs? Is it developmentally appropriate? Maybe it's not the right age or the right education level. Is the information new, or is reinforcement required, or has it already been provided? Is the content presented at the client's level, like I said, developmentally or otherwise? And does the content relate to the client's life experience or otherwise relevant, right? And that might have to do with, for instance, if somebody has a head injury and maybe it's related to some sort of wartime injury, right? And we present some information based on an auto accident. That's not relevant to what's going on. It's not relevant to what happened to them. And that might be a barrier for them to identify with that, right? And then finally, what's the right method? Does the teaching strategy fit the learning style of the client? Like we said, I'm a visual learner, or I'm an auditory learner, or I need to feel it. Those are the strategies you can put into place and to make sure it fits the client's learning ability. And then, are the teaching strategies varied depending on what the needs are, right? So it doesn't get monotonous and maybe is challenging. Okay, so factors that affect the client learning. So we're talking about motivation, right? And this is the desire of the patient to succeed. It's created by an idea. So it's either internal, a physical need, or an emotion, or some other kind of force. Sometimes motivation can be external, but it's greatest when the client recognizes the need for the learning and believe that it's possible to improve their health. So they connect the change with something positive, and they're interested in that information that they're being given. Okay, so that's motivation in a nutshell. If we can capture that, readiness to learn is a different animal. This is the demonstration of behaviors that indicate that the learner is motivated and able to learn at a specific time. Right. So you might give this information to somebody, like for instance, somebody that tries to stop substance abuse. Right. They may go to a rehab facility many times, and for whatever reason, doesn't get sober or doesn't stay sober. And then at one point they go and everything changes for them, right? And that has to do with a lot of variables, but one of them is the readiness to learn and to accept the change. And so some of the things that can play into that is physical condition. So for instance, what kind of pain are you in? Do you have strength? A post-stroke patient, for instance, do you have the energy, the senses, the mobility? Do you have the intact cognition, right, to contribute to that situation? And then emotions, severe anxiety, stress, or emotional pain interfere with the ability to learn. That makes sense, right? In addition, the learning itself, that behavior must be changed, can create anxiety because it's a huge change for people, right? And sometimes that can be hard to take on. I had a patient early in my career that was a Marine that ended up getting colitis, and so ulcerative colitis. So he had a colostomy, and he was 17 years old, and his girlfriend was in there with him, and he was having a very difficult time accepting the change. And it was a hard thing to watch. And so this is what we're talking about, right? This is a situation where the client is not in a place where he's going to be able to be motivated to make any changes yet. You have to deal with some of those emotions first, and it's a skillful thing to do. And sometimes we can't do anything. And that brings us to our next point, is timing. Clients retain information better when they have an opportunity to use it as soon as possible after it's presented. So for some context, concepts, the learner might need more time to absorb it or whatever, but sometimes it can be done right away if complex thinking isn't required. So active involvement is also another one, and that's learning is more meaningful. This is the idea, is more meaningful when the client actively engages in it, right? So learners retain 10% of what they read, they say. This is London, but they retain 90% of what they speak and do, right? So if you can combine those things, then that can be a very high effective rate of learning. When we give feedback, positive feedback encourages learners and boosts morale when it comes to tackling difficult content or devoting the time and effort needed to get the most out of educational process. When we're trying to create an opportunity for someone to learn after some sort of a serious injury, this is really never the time for corrective feedback or constructive feedback. Positive feedback is really what we want to give people to encourage them to find the strength to do it and to find a time when they're ready for that, okay? Repetition is also important. The client's more likely to retain it if they do it more. Makes sense, right? And then learning environment is, an ideal learning environment is like we talked about, it's private, it's quiet, it's comfortable, and it's free from distractions. So that's what we hope to see. It's not always common we have all of those. Okay, so factors that also can affect the learning is scheduling of the session. So if you come in and you say, hey, guess what? It's now time for you to learn how to change your colostomy bag, right? That's going to be probably a little bit of an imposition, right? Potentially for the patient, particularly if maybe their girlfriend's there and that's embarrassing to them. So you're going to want to try to facilitate. Maybe there's a good time for that, right? And they'll say, yeah, my girlfriend leaves at 1. Let's do it after that. Okay, great. That's going to give you a much better chance of helping them, and they'll be more receptive to it. And then even potentially a time for you to build rapport, right? When it's just you and them, and you can help them one-on-one. The amount of complexity of the content. So some ideas are very complicated, right? If you're going to teach someone to do their insulin, that's a lifelong thing, and that's not something that they're going to get right away, particularly when you have to really understand your food sizes, right? Your what do you call that? Serving sizes, and the types of carbs versus protein and fat. And some people don't know that information, right? So that's going to be complex. But some things are very easy to learn, and so the greater the change, the greater the challenge is, right? And so you're going to have to consider that. Next is the nurse-client communication. So we've talked about this many times, but the barriers to communication are the same they can be anywhere else. And plus things like pain, anxiety, fatigue. Nobody sleeps in the hospital, right? I mean, they sleep very little. So they're always going to be tired. They're most likely going to be ill. They're probably going to be hungry. There might be dysfunctional relationships because their family is stressed out. There might be language differences, right? Hearing or vision impairments, cultural factors, all of that kind of stuff. So we work in a dynamic environment where that can be pretty challenging. Special populations are also important. The things that you'll do will depend on the nature of the special need, right? So it might include a family member that has special needs. And by special needs, it could be anything. It could be a family member with Alzheimer's that is not a good historian, so that they're probably not a good choice to give educational material to. It could be the patient that is just waking up from surgery, right? So there's lots of things to consider. For instance, maybe there's a caregiver instead of a family member. Those are all things that you'll be managing on an ongoing basis. The developmental stage is also important. So understanding where they are on that ladder is going to help you develop your strategies. And obviously, if you aren't targeted into that area, then you're going to find yourself giving information that can't be received. Culture is also important. We talk about that all the time. That involves respect for an individual's identity and needs, and where they're from, how they speak, how old they are, what religion, how much money they have, or whether they're disabled. None of that really matters. Really, all that's important is that we treat everybody the same, and that you understand how to meet their needs. So we do that by being sensitive to their culture and understanding what we can. And the best way to do that is to ask. Health literacy. This is the ability to understand basic health information. Some patients don't understand basic health literacy, right? Some people are they'll come to the doctor's office with recommendations for the physician, right? And maybe they've already put it into ChatGPT and everything else. So health literacy is continuing to become better and better, but there's definitely a lot of pockets of socio-demographic groups that do not have great health literacy, and that affects ultimately their access to care and their outcomes. Okay, so barriers. These are barriers to teaching and learning. Now, this is barriers for the teacher, right? And that's the nurse in this situation. So, competing demands on the nurse's time is always going to be a challenge because it impairs your ability to prepare for the teaching, right? Makes you more likely to have to do it on the fly. Conflicting schedules between what you have to do and what the patient's available time to learn is. Ineffective coordination of class lecture with clinical experience. So, for instance, maybe you haven't learned some of the materials that you're in clinical for, and you're expected to teach them, right? It's like, I haven't even had that class yet. That's happened to you guys, right? And because I've heard that from some people. So that happens, and that always happens. It's something you can't avoid, but that can be a barrier as well. Lack of space and privacy. Sometimes you're trying to talk to a patient and there's not a room to tuck into, and you have to keep that confidential, right? So teaching is often seen not as a priority, either by you or by the organization. So there might not be a high degree of resources dedicated towards that for whatever reason, right? Well, there's no third-party reimbursement for teaching. So until they pay nurses to teach patients and reimburse the hospital for that. That's probably not going to be something that is developed the way reimbursable care is, right? That's just not the priority. But of course, we do it because it's the right thing to do. But it's always seen as something that is an additional I guess you would say burden to carry, right? But we don't see it that way, but sometimes it can be viewed that way. And then documentation frustration. You'll have it, you'll hear people talk about it. It's real, but it's the reality of what we have to deal with, right? Okay, now let's talk about barriers for the learner. This is for the patient, right? We've talked about these a lot. Illness, fatigue, anxiety, low literacy, environment isn't conclusive and conducive to learning, lack of time, ton of behavioral change, right? A big new change, complexity of the condition, et cetera, right? So these are all things that are barriers, even perceiving not to have a need for the information, right? Like one time I had this patient come to me, and we were talking about weight loss, and she was saying to me, you don't have to tell me all about the foods that I eat. I'm a nurse. I know all those. And I said, yeah, I know, but so do I. And all of us have trouble with that sometimes too. It's not just about understanding what it is, but it's part of the process to reinforce, what these healthy behaviors are, right? And so that was my best answer in that situation. Barriers to technology-based learning. Some people don't have a lot of social interaction. Some people have poor learner motivation. There's different styles, technical problems, right? Maybe you give them a learning device and it's broken. They can't do the training. Maybe they don't have access to the internet, right? Lots of different things can be in the way. All right, so let's talk a little bit about this. So suppose you're the nurse planning discharge teaching to a frail elderly man who suffered a stroke. He'll be cared at home for by his daughter. What's the best approach for planning discharge teaching, and how might the nurse show caring for this patient? So the nurse would probably approach this in the best way to say, probably including caregivers, right, or family members. We want to include the family, especially people that will be involved after discharge. We want to create a good environment for learning by, I guess, non-threatening environment, reducing distractions, speaking slowly and in a normal voice, covering the need to know information first, and then support some of the more specific ideas. A lot of times what we do with this is we'll provide all of the information, but then we'll also provide a written document so that, because a lot of times patients will get the need to know information and the rest will just go right over their head because of the situation. So we give that to them so they can refer to it later. By the way, don't be surprised. I had surgery once, and I was really surprised at myself. I barely read the pre-op information, and I didn't read the post-op information once. So, if I don't read it, I'm pretty sure none of my patients read it either. So you have to assume that sometimes. We're going to present a little information at a time and not to overwhelm them. Phrase our instructions with action words. So too many words can be, confusing. So we talk about action words, right? Things that help us feel empowered with the work that we're going to be doing. And then repetition and reinforcement. One of the ways we can do that is we show return demonstration. What this is I tell you something, I show you a procedure, and then I watch you do it in front of me, and then you have returned to the demonstration. That is the highest observation that you have the information, right? You're able to do it independently. And the way we show caring is that we allow plenty of time. We don't rush them. We find a private space to include whatever the patient's needs are, their caregiver or just them. We make sure the patient is comfortable and rested and pain-free if possible. And then we consider life experience. We understand the big picture about what we're trying to tell them, and we leave space for them. Okay, clicker check. Nurses must possess the knowledge and skills needed for patient teaching so that they can complete the documentation forms related to client teaching accurately. They can help the hospital meet the Joint Commission standards requiring client teaching. They can promote the health, safety, and rights of clients through education. Or D, they can meet the patient rights delineated in the patient care partnerships. Oops. Just going to share my screen for the next half of this lecture. Hang on one second here, guys. There we go. Okay. So let's see. Excuse me. Nurses must possess the knowledge and skills needed for patient teaching so that A, they can complete documentation forms related to client teaching accurately. B, they can help the hospital meet the Joint Commission standards requiring client teaching. C, they can promote the health, safety, and rights of clients through education. Or D, they can meet the patient rights delineated in the patient care partnership. What do we think? Well, we talked about C as far as the code of ethics and promoting health, safety, and the rights of clients through education, right? And that, I believe, was the ANA code of ethics. Okay, that's our interpretive statements that hold us responsible for the health, safety, and rights of patients. And that's regarding teaching. Okay. All right. So components of a learning assessment. So the intended audience, this is going to be important, right? So you have to think about when you're performing an assessment of this learning need, who are you teaching? right? What's the client's age? What's their background, their occupation, developmental level, cultural influences? Will you be teaching a person or a group? That's going to be a very different plan, right? What's the client's medical or other problem or other problems, health problems? What behavioral changes might be needed? What self-care knowledge does the client need, or what do they possess? You can determine what the client already knows for their knowledge level so that you can reinforce that. Or, there's nothing worse than telling somebody something they already know and they feel offended by that, right? So you can ask questions like, what do you think caused your health problem, or what do you already know about this? What are your concerns about it? Has the problem affected any other activities? What are your concerns about treatment? These are all good questions that will elicit healthy responses and start that conversation. All right. So, health beliefs and practices, you can ask the client to give a general description of their health. You might just say, from zero being really bad health to excellent health being 10, where are you at, right? And you can understand what they believe about themselves. What do you usually do to stay healthy? What problems do you think you're at risk for? What lifestyle changes would you be willing to make? So that's a good question for someone, for instance, that's smoking or needs to change their diet. Okay, fine. You can't change the world right away, but what's one bite of the apple that you can take today? And sometimes that can roll into more momentum. Physical readiness, you want to check their ability to concentrate, check their dexterity skills and pain level. Emotional readiness, find out if they're experiencing anxiety or any kind of distress, any stress. And if that is an issue, you can ask if they would they would like a family member or somebody to be present. We're going to check their ability to learn. So what are their cognitive abilities? How does the client learn best? How does the client recall previously presented material? Do you have a sense of that because of your time with them? Is their health literacy level? Is there anything remarkable about that? Do they have the ability to understand their basic health information? Can the client read and write? It's important. Does the client and healthcare provider speak the same language? And then we talk about neuro and learning styles. So neurosensory factors, can the client feel, see, hear, and grasp? Do they have all their senses? If we're going to ask them to write something and they can't grasp something, then we should know that, right? Does the client have a medical condition that causes neurosensory compromise? Is there any kind of neuro status issue that we should be aware of? Because that's going to affect learning most likely, right? And then the last thing in this long list is learning styles. Ask how they prefer to learn new things, okay? And if they're not familiar with different styles of learning, ask them if they prefer to read or watch a DVD or listen to a teacher or things like that, right? So you can ask them where they get their information from, and that can give you a sense of how they do that. Are you best learning alone or in a group with other people? Those types of things. So deficient knowledge is the most frequently used NANDA nursing diagnosis, okay, of a teaching plan. And so sometimes it's a problem or the etiology. So you should use deficient knowledge only if you believe that the lack of knowledge is the primary problem. Okay, so we've talked about this before in class. Use it to describe conditions when the patient needs new, additional, or extensive knowledge. Don't use it routinely as a problem label for all patients. There's information that it needs associated with almost every medical and nursing diagnosis. So this isn't something that you say every one of your patients has, but for most diagnoses, you can write a nursing order to provide the informal teaching. But we don't use deficient knowledge for problems involving the client's ability to learn. Okay, so it's only just an opportunity. It's not, it would be more of a medical diagnosis if we talk about that. It's an opportunity to learn things that they don't know. Okay, so when you're planning a teaching plan, we contract with the learner, right? Verbally or whatever, and we do a learning contract. And it's an understanding of between the nurse and the client on our mutual set of goals. And that can be, like I said, verbal, it can be in writing, but it's important that both have an understanding, and it can be informal, but it's really important that both people acknowledge and focus on a goal, right? So when you're teaching a goal, usually it's good to set down what's expected as the final outcome. All right. They should address all of the domains of learning, and they should talk about learning objectives. All right. So these are single behaviors. You see them a lot of times at the beginning of our slides. And it says during this slide, this presentation, you will learn this, the learner will learn this, right? And so this is very similar in the nursing process. When we do learning objectives or goals, it should contain an action verb and an activity that can be measured and observed, okay? All right, the client is given a pamphlet to read about how to manage their newly inserted central venous access at home. It will be the most important for the nurse to assess the client's health beliefs, literacy level, fine motor abilities, or ability to see. All right, well, let's see here. So health beliefs, literacy level, fine motor abilities. All right, so the client's given a pamphlet to read about how to manage their newly inserted central venous access. Fine motor, I don't think that's probably going to be important, particularly. Literacy level, perhaps. Health beliefs, maybe. Definitely literacy level could be an issue for reading. And then ability to see, obviously. So I think it's probably B or D, but my answer would be probably to select D over B, the ability to see. Yeah, because the patient has vision problems. So you obviously have to change the strategy to address that issue. Okay, so let's talk about components of a teaching plan. Teaching strategies, the method used to present the information. These are examples would be like a written information, demonstration in return, or one-on-one instruction and mentoring. Okay, the content includes information that your client has to understand to reach the desired goals. So this could include facts that you include, skills or emotions. All right, and then scheduling and sequencing. As a general rule, you should present simple before complex topics and non-threatening topics before threatening topics, okay, or controversial ones. You should also determine when this session should be scheduled, as we've talked before. When there's extensive content involved, it's best to make sure that that's formally scheduled and that the client is committed and prepared prior to the session, okay? Instruction material, these are just tools that are used to introduce the information and reinforce learning. Okay, so examples of teaching strategies. We use lecture. It's effective and efficient, right? And it's a good way to impart information to large groups of people, and doesn't allow for individualized teaching though, right? And so a lot of times that's the drawback. Group discussions are great. Several participants discuss topics, exchanging information and presenting their points of view. The nurse acts as a facilitator to achieve objectives, sharing with the group at the beginning of the session. So this would be something like brainstorming, or even like, for instance, a 12-step meeting where there's facilitation of an ongoing topic, right? The demonstration or return, the nurse explains and demonstrates the skill or the task. Then the learner demonstrates it by returning demonstration, okay? This is something that you'll see as it's a standard of care. It's a best practice that when we discharge somebody, whenever possible, if it's possible for them, they return demonstration of the behavior that they're going to need to conduct. Or at least we teach that to them. And if there's a caregiver that can show us that as well, then we also will do that sometimes as well. And then, of course, there's one-on-one instruction or mentoring. And so that's just one person working with another until they're close and understanding what needs to be done. And then we have digital and printed materials. So this could be, you know exactly what that is, anything from books to online material and anything in between. And then, of course, online sources like the CDC or other government websites and things like that as well. Okay, So when we're evaluating learning, one of the things that's important is that we're going to, these are some of the commonly used things for outcomes evaluation. All right, so when we're evaluating learning, we're going to want to look at oral questions, interviews, and questionnaires and checklists. These allow the clients to evaluate their own progress. Okay, so you can obtain more information by talking with the client, but you might get more honest responses with like an anonymous written evaluation, for instance, right? Particularly with things like sexual things or anything that might be considered embarrassing. Direct observation of a client is when descriptive notes are made of the learner's performance. So you might be observing them and reinforcing accurate learning or correcting something that maybe wasn't done the way you specifically are hoping it's done. So that's allows for direct correction in real time. And then the client reports and client records of performance and results. You can evaluate that data and give feedback. So that might be related to other things that they've been documented previously or things like that. And that gives you an objective source of data. And then tests and exercises. So this can be used in a formal learning setting to measure retention and progress, things like post tests or assessments. Okay. I hope you've enjoyed this. Sorry about the first part being blank, but that's okay. You can follow along with your PowerPoints and then catch me up halfway through. I hope you have a great test, and I'll talk to you soon.